I am Meliha Yetisgen-Yildiz and I lead the Bio-NLP group at UW. I'm an assistant professor in the biomedical health informatics, as well as I have an adjuncted with the computational linguistics department. This is my group. Our website is here. This is like the group members. We have 2 faculty additional to myself, one from Department of Linguistics and the other one is from Microsoft Research. We have some grad students and clinical collaborators. What we do is mainly to process electronic medical records. And of course, it's both involves structured part and unstructured part. But what I'm more interested in is, of course, the free text form, mainly clinical notes, and to be able to process them. This is, for example, an example discharge summary. What we usually like discharge summaries, we work with them a lot. So mainly the also reports, we are also interested in extracting test information, such as like these types of tests, and also as well as treatments. There are also other types of information available in clinical notes, also including like temporal values, negation information, numeric values, uncertainty. For example, uncertainty is one of the areas that we were very interested in because so for this one, for example, patients' allergies include a questionable penicillin reaction. So it's not present or absent, but questionable, so it's in between. So, and also as well as like associated with someone else. These reports, especially discharge summaries or admit notes, have a family history section, which usually talks about the condition which is not associated with the patient, but someone in the family. So my area is mainly natural language processing, and I work in this domain because this is a hard problem. So it's kind of a challenging and fun one. And what I do in this domain is mainly statistical natural language processing. My training was mainly on machine learning and data mining before NLP. So I wasn't trained as a linguist before, but I collaborated with lots of people from the linguistics department for that piece, because linguistics is a huge portion of NLP, but I apply statistical methods to understand and model the language. I will be talking about a couple of the projects. So the first one is document segmentation. Here the problem is we have a report, and to be able to understand which pieces of information is available where, we need to chunk it into main sections. And here the problem is mainly to identify the boundaries of these sections and then to be able to map those sections into appropriate section headers. This is a quite interesting problem, difficult problem, because when you try to do it with a rule-based approach, because like clinicians usually tend to use so many different representations for these headers. So it's very difficult to do it with rule-based. Rather, we built a statistical section segmentation framework where we created an ontology. We created this manually for each report type. We started with radiology reports and discharge summaries. So we created an ontology for radiology reports, such as this one. This is a very basic, of course, ontology, where we know that these kind of representations are under clinical information. These are represented under exam details, like so on and so forth. And then we annotated a small set of documents with that ontology. And then we trained a 2-level classifier, where the first classifier determines the boundaries of the sections, which is a very easy problem because it's a very sequential classification problem. And the other one mainly classifies based on the identified sections which class it belongs to in the ontology. We trained a maximum entropy classifier for this one because we tried 5 or so classifiers, and this one happened to produce the best results for this classification task. And for discharge summaries, we identify with 95% of precision correct headers. So discharge summaries is far difficult than radiology reports because they have a larger ontology. And with radiology reports, our precision was 93%. So usually the mistaken ones came from errors, such as some of the time, like the discharge summaries were not discharge summaries at all. They were classified as discharge summaries in the EMR, but they were not. So in fact, our performance is a little bit higher than this, but still these are the numbers. The second problem we worked out is assertion extraction. So this problem is mainly you have a context, you have a sentence, you have a medical concept. The problem here is you have the sentence, you have the concept in the red, and you try to understand whether it's present, absent, conditional, hypothetical, possible, or not patient. So So this problem is really important because like whenever we do in our phenotyping projects, when we create a feature space right out of unigrams or medical concepts without getting this context into account, we end up getting so many false positives and false negatives. Because, for example, like if you are classifying for pneumonia, if it sees pneumonia here, for example, for this patient, then it would definitely classify it as positive for pneumonia, even if it's not. This is not a good example, but suppose this was not pneumonia, like it would be a false positive. So that's why assertion extraction is important. So what we did for this one, again, we created a statistical approach from a data set publicly available through ITV2. And this was a good example because this wasn't UW data. This was Pittsburgh data. We trained the assertion classifier on this data, and we applied to UW data. And we get reasonably well performance values. So very close to the performance values I'll show soon. So for this project, again, we use full statistical. We use supervised SVM-based classification framework. We added so many like syntactic and semantic features. We added dependency trees. We added like stemming information and so forth. And we got reasonable, like really good performance values. So we are the best system published in this domain right now. So we can really identify these categories well, like absent and present, like really well. We have some problems with the like gray areas, such as conditional, hypothetical, but these are very, very difficult to catch anyway. So this is another problem that we recently finished, and these two tools, like this has been released through our website. The section chunker will be released next month. So we are currently working on the packaging of the tool. So what we currently work on is medical event extraction. And so the problem we currently try to do here is how can we define medical events? So what medical event means in the context of clinical text, what arguments and attributes they have, and how can we use temporal information available in clinical text to order the medical events. So this is kind of important because like even if we add assertion on the top of features, it wasn't sufficient for us to capture certain phenotypes, which I'll be talking later. So to be able to capture the progression of the disease, usually like to have one snapshot of time is not sufficient, but to see the whole history makes more sense. So this project we started because of that. And we started with longitudinal chest X-ray notes, where these notes are like, these are coming from the same patient on different ICU days. This patient was in the ICU, I guess, for 14 days or so. So he had some chest X-rays like on multiple times on certain days. But the interesting part is like, the event here is diffuse lung opacity is consistent with pulmonary edema. So this is the event that we are interested in. And on the second chest X-ray, it says no change. In the third exchange rate, it says worsened. In the fourth one, no change. And in the last one, gradual improvement. So if you lump all these features, like all these reports together and create one feature space, and classify based on that, you end up getting a false positive because this patient is not in fact positive for pneumonia, but this is like apparently a very, very strong feature for pneumonia, and so it was not like good representation. In this project, we created a structure with change of state, and this is we created this annotation schema recently, where we captured the location, attribute, value, change of state, and reference of an event. And we started annotations where we annotated 1,000 radiology reports with this information. And this is a visualization tool called BRAD, which we use for annotation. So we did this annotation, and we are at this stage right now. So we are publishing right now, writing papers on to describe this corpus. And what we are going to do, of course, is we are going to build a learner so that we can extract these events with their attributes and their links together, and then we are going to use it in phenotyping. So this is ongoing research, and which I'm very excited about. In the second part, up to this part, I talked about the NLP projects, really like the research we sent to computer science conferences. So this part, I sent these to biomedical informatics conferences and journals. So these are the applications of the features that we extract from the first part. So the first project is like, I'll just skim this very fastly, but this is about critical recommendation extraction from radiology reports. Here, I collaborate with radiology department and ITS for this project. And here the problem is, you have this example radiology report, and this patient has been admitted for trauma. And however, the radiologist looks at the image, sees a nodule in the left lung, incidental, and he makes a note here. So this has been a problem because sometimes the referring clinician just reads this part because patient has been admitted for trauma, so they miss this part and the patient goes on the radar and just ends up getting cancer. And UW has been sued twice for this problem. So my collaborator we started a project to be able to capture that. So what we did was, we created a data set again. We included so many reports not to hit the overtraining problem, so that we have a mixture of imaging modalities. And we have an annotation. 2 annotators annotated these reports for recommendation information just for the sentence boundaries. So they just highlighted the sentences that would include such a recommendation. And the task is you mainly learn how to predict these sentences so that they can be maybe highlighted. So we again created a machine learning framework for that. Section information is really important for this task. Sentence segmentation is really important. And then, of course, the final part is the recommendation extraction piece. So again, we use lots of features to be able to represent that. And we created a learner which predicted in terms of predicting the boundaries of these sentences. But it happened to be that these sentences include so much hedge features. So we are trying to make it better performing right now to eliminate the hedge sentences which destroyed our performance. And we are interested in trying to extract more information about these recommendations, including what has been recommended, why has been recommended, and when recommended, so that this information can be used to create a database for monitoring purposes. And this is we submitted a grant which is under review, which is hopefully we'll get it. Hopefully, if the NIH shutdown is okay. So anyway, so the second project is which I spend most of my time is phenotyping. So the first project is a side project compared to this one. And in this one, what we try to do is we try to model the progression of critical illness phenotypes in the ICU domain. So we have these ICU patients, and we collect their reports and their all data. And we try to model mainly the progression and determine the time of onset. So we have 3 modes for this project. The first mode is mainly the head phenotype setting, where we have this patient, but the task is really to look at the past. So these patients has been treated, their all information is in the EMR, and the purpose is to be able to create a cohort for research studies. So we look at the whole reports, and we try to predict the past. In the second one, the has phenotype setting, we have the timeline, and we try to predict at a certain time point whether the patient has the phenotype or not. So this is where mainly phenotype surveillance kind of task. So we try to determine at a given point of time the number of, for example, patients who are positive for pneumonia. And the third setting is the will have phenotype setting. We try to predict the future, where at a time point t, we try to calculate the probability of a patient acquiring a certain phenotype. So And this is for mainly clinical decision support systems. So this is a large project. This project has been funded by Microsoft Research for the last 2 years, which has ended like recently. So for that part, we focused on the head phenotype part, which were trying to build a cohort, and we did some work on the has phenotype type. But we are currently working on the will have phenotype setting. And for the first part, we had a data set of 400 plus ICU patients. We had all these reports, and they were annotated for the positive or negative being positive or negative for pneumonia. And we developed a supervised learning framework where this is the main baseline. So we have the patient records, we have a feature extractor which uses MetaMap, which is a UMLS concept mapper which identifies all the medical concepts. And then we trained a basic pneumonia learner. And then we published this baseline, and then we extended that with statistical feature selection, because when you end up merging all patient reports, the feature space explodes, so which gives us very bad performance. So we applied statistical feature extraction, assertion classifier. We also added section information into the framework, and then we enriched this pneumonia classifier, and we ended up getting really good results. So we ran, I won't go into details of all these experiments, but usually what we found is like compared to the baseline, which is F score is 50%, by adding all these other features, we increased it to 85%. As I said, we are in the current research, we're in the process of building a classifier that determines the time of onset of a given phenotype. For that one, we have a data set of patients where their ICU stay, we have all the data, and it has been annotated for presence or absence of pneumonia, and on the top of that, the day of ICU day. So, for example, it will say number 10 is positive for pneumonia on ICU day 5. So we try to predict that, like we trained classifiers for each ICU day, and it predicts like whether the patient is positive or negative on that day. So we have some papers on that, and of course the more difficult problem, prediction of next day, which we created a data set with Heather Evans from surgery department with Tony, and it's a very complicated and complex data set where we have 600 plus patients, I suppose. We have all their ICU notes plus all their structured data, and we try to predict the future based on that. And it's going okay, but our performance right now at the F-score 30 level right now. So we are making some things really wrong, but it's quite fun to work with right now. So because like F-score 30 means that we have so much room for improvement. The third project is SCOPE. With this is mainly clinical collaborators Dave Flum, and this is a mainly a quality improvement project where we have these surgical patients, and so many data elements are collected for them for quality improvement purposes. And the problem was I lead the NLP part of this project, and which the project has ended end of September though. We are trying to build NLP approaches to automatically infer some of these data elements so that it will decrease the workload of the annotators. So one example is, for example, comorbidity extraction. Like comorbidities are extracted for patients, for example, obesity, like diabetes, asthma, hypertension, sleep apnea, and also smoking status was one of the data elements. So because we are trying to extract these so many data elements that are coming from different nature. For example, some smoking history is very different in nature than comorbidity information. So we had to build a text processing infrastructure for this one. And mainly what it does is it takes a free text clinical report, it processes them, and for a given data element, it mainly selects either it needs to apply a rule-based extractor or a statistical extractor, and then produces the results. And for this project, we had to build some rule-based extractors because apparently for this project, for example, for comorbidities especially, the annotators were annotating hypertension if they see the term hypertension or hypertensive in the text, but they weren't making any inferences, such as if they see a drug name, for example, used for hypertension, they weren't annotated that as positive. But when we built a statistical model, of course, it picked up all these drug names and everything as features, and we started to get these really low performance compared to what is called gold in this text. So we had to build some rule-based extractors for this project.